I'll be talking about fracture radial, head, neck, and Olecranon in children. Me, Dr. Tapas Talukder, working as an assistant professor, Department of Orthopedics, Shohid Ziaur Rahman Medical College, Bogura. First, about fracture radial head. First of all, we should know the ossification process. Everybody of us know that the ossification starts in radial neck, radial head at 3 to 4 years of age. At 4 years, as you see in the X-ray, it is very tiny, and with age, it gradually increases in size. And for the most part, it is mainly cartilaginous, so fracture radial head may be totally unappreciated. And in case of neck, a fracture radial neck may be seen as a small metaphyseal fragment on X-ray. So in case of management, high index of suspicion is a must. We should know acceptable range of forearm rotation, which is important in making decision and regarding choice of treatment. 50 degree of supination and 50 degree of pronation is sufficient for the functional range of movement of the elbow. Isolated radial head fracture is very infrequent in children because the immature radial head is merely cartilaginous, but it may occur. When it occurs, it is usually of Salter-Harris type 3 or 4 type of injury. And management may be conservative. If there is minimal gap or there is a minor fracture, we can go in conservative treatment. But if there is a wide gap and wide separation of the fracture, this epiphysis, we may have to go, if possible, for operative treatment. And there may be some complication in radial head fracture. There may be progressive radial head subluxation, development of radiocapitellar arthrosis, avascular necrosis of the radial head, and progressively development of valgus elbow. You can see in this X-ray, this is the Salter-Harris type 3 of radial head fracture. It was fixed with open retraction and internal fixation with 2 trans-epiphyseal screw. This is a 6 weeks post-op X-ray, and after 6 weeks, we can get functional range of movement, which may be adequate for this baby. Then I'll go for radial neck fracture, which is the most important topic of my presentation. And in case of radial neck fracture, this is more common than fracture radial head. Neck fracture is more common. And it typically occurs at the metaphyseal region of the upper radius, but can extend into the proximal radial physis, which can produce a Salter-Harris type 2 fracture type. Approximately 1% of all children's fracture and 5 to 14% of pediatric elbow fracture is fracture neck of radius, due to fracture neck of radius. How it occurs? It can occur primarily, that is acute trauma. We all know carrying angle in pediatric age group a bit more. It may be up to 13 to 15 degrees. So it is anatomically valgoid. So if a baby fall on extended normal valgoid elbow, a valgus force acts on the elbow, and there is a compressive effect of the radial head over the capitulum. Radial head is usually cartilaginous, and the fracture occurs in the neck region. Secondarily, it may occur in association with Montegia 2 lesion or Montegia equivalent lesion. You can see in the X-ray here, there is a posterior angulation of the ulna, fracture ulna, and the radial head is in position, but after breaking at the head neck region, there is posterior shift of the proximal radius. Here also, radial neck fracture may be associated with Montegia type 2 lesion or Montegia equivalent lesion. It may also occur during the process of elbow dislocation. Here, you can see in the diagram, during the process of elbow dislocation, and here the fractured head fracture fragment lies usually anteriorly. Head fractured portion is anterior. It may occur during the process of reduction of the elbow. Here, as because at the process of reduction, the posterior part of the lower humerus got compressed with the upper portion of the radius, and there is occurrence of the fractured neck of the radius, and here the fracture fragment lies usually posteriorly. Here you can see the neck is in posterior position. So, every case of pediatric elbow dislocation must be thoroughly evaluated before and after reduction for hidden radial neck fracture. So, we should do something after reduction or during dislocation. There may be 3 degrees of displacement. One is angulation. Here the fracture fragment is angulated with the proximal radius. There may be translation. This part fracture fragment is translated, or there may be complete. And angulation and translation may be occurred in the same scenario, same injury. There may be some associated injury. We must have a good look for them. There may be fracture medial epicondyle. There may be green stick fracture of the ulna or Olecranon, or there may be radial or ulnar collateral ligament injury. And management of this injury is of utmost necessity for proper elbow function. How we can diagnose? Making the diagnosis, as I have told before, may be difficult because of unossified or merely ossified radial head. The only sign may be a small metaphyseal fragment, but a radiocapitellar view can be helpful in making diagnosis. How we can make a radiocapitellar view? Our X-ray technician usually may not be aware of this view. As the diagram shows, we must have to place the forearm in the X-ray film, the forearm in supination, elbow posteriorly, forearm in neutral position, and the X-ray beam is projected at 45-degree angle of the joint. Here, the head neck region of the radius can be seen properly, and this is called radiocapitellar view. In case of high index of suspicion, or in case of suspicion of other associated injury, we may have MRI or CT scan of the elbow. Now, how to classify the fracture? There are many types of classification like Jeffrey, Judet, Wilkins, Metaju, and I am showing the Judet classification with some modification with Metaju. And this classification has influence on prognosis. This is divided into grade 1 to 5. Grade 1, there is minimal or no angulation and the translation below 3 mm. That is grade 1 injury. Grade 2 injury, here also the angulation is below 30%, and below 50% translation. Grade 3 variety, there is angulation is 30 to 60 degree and translation is 50% in relation to fracture fragment at proximal radius. Grade 4 is divided into 4A and 4B. In case of 4A, there is angulation 60 to 80 degree, and 4B angulation is more than 80 degree, and separation is more than 100 degree, that is complete separation. And if there is Salter-Harris type 2 fracture, that is epiphyseal separation, they fall it in grade 5 injury. And this classification has influence on management and prognosis also. How to manage? If the angulation is below 30 degree or translation is below 3 millimeter, usually conservative treatment is adequate. Any manipulation or attempt of reduction is not needed and may be harmful even. So, non-manipulative conservative treatment is sufficient. Here only long arm back slap is applied for 3 weeks. And after 3 weeks, the back slap is taken off and gradual range of movement exercise is begun. This literature, radial head neck fracture in children, experience from 2 level 1 trauma center. This is done by Basmajain, Choi et al. This literature shows excellent to good result obtained in 89% of cases where it is treated with casting alone. That is conservative treatment. And here the X-ray shows this is an X-ray of a 9-year-old girl. There is translation, this is accepted, and in 3 months, there is complete remodeling in conservative treatment. So up to 3 millimeter on translocation can be expected to remodel. If their angulation is significant, that is more than 30 degree, translation is also significant, that is more than 3 millimeter, we should have go to close reduction. Here, there is 3 methods. One is Patterson's technique, second is Kaufman techniques, and third one is wrapping the arm with an isthmus bandage only, sometimes may be successful. I am showing the diagrammatic figure of Patterson technique. Here you see elbow in extension. The surgeon's thumb is on the fracture head, traction and counter traction. I am showing in details. Here, surgeon applies distal traction with forearm supination. Assistant holds and put a counter traction proximally and applies a medial to lateral pressure. And during this manipulation, the forearm is rotated to make the radial head most prominent. The fracture part should be made more prominent by gradually rotating the forearm in supination on rotation according to the fracture pattern. Then surgeon applies a direct digital pressure to the radial head, and distally a varus momental force is applied to open up the radiohumeral joint, and it usually becomes successful in close reduction technique. And this is the maneuver was in flexed position. This maneuver is devised by Kaufman, who is from Israel, and his colleagues. Here, elbow is in flexion. Here, direct pressure is done over a flexed elbow by the thumb of the surgeon, and here in this way, direct pressure over the radial head with the thumb is applied. Sometimes this is an X-ray where the extremity was tightly wrapped just prior to proceeding to an open reduction. No open reduction. First, we must have to try other technique before opening the injury. In this case, the extremity was tightly wrapped just prior to proceeding with an open reduction, and by this wrapping technique, best reduction is achieved. And there is anatomical reduction which was achieved with elastic wrap alone. The same literature shows excellent to good result obtained in 69% cases in close reduction group. If this maneuver fails, all these three maneuver fails, what to do? There is semi-closed method of reduction, two types. There is two maneuver. One is percutaneous assisted reduction, and other is devised by Professor Mataju. He is from French. Here, flexible intermediary nail is used. I am elaborating. This is a diagram of percutaneous assisted reduction. This one is the fracture. One strong Steinman pin is introduced just above the fracture to the head neck region. There is some leverage technique, and by which the reduction is achieved. And here is the literature by Song et al. Percutaneous leverage reduction for severely displaced radial neck fracture in children. They concluded percutaneous pin leverage reduction followed by fixation with advancing of pin is a safe and effective method to treat a severely displaced radial neck fracture that is more than 60 degrees without serious complication. Here, several methods of percutaneous leverage, semi-closed method, many manipulative devices like Steinman pin, owl, or surgical elevator. But we must keep in mind there is every chance of posterior interosseous nerve injury. So we must have to pronate the forearm to decrease the risk of posterior interosseous nerve. We must have to pronate the forearm and introduce from the posterior aspect so that the posterior interosseous nerve goes anteriorly and there is chance of less harm to posterior interosseous nerve. This is an injury film. Here, best position obtained is 45-degree angulation. This is unacceptable. You think this is 45-degree angulation? So we must have to do something. Here, this is achieved by percutaneous leverage technique, and it can also be done with a surgical elevator also. And satisfactory alignment may be achieved with this technique. The same literature shows excellent to good result obtained in 73% cases in closed reduction and percutaneous pinning. Here is another literature. Percutaneous reduction of displaced radial neck fracture achieves better results compared with fractures treated by open reduction. They concluded in summary, and the authors believe that most radial neck fractures in children can be treated by closed reduction or percutaneous assisted techniques, while open reduction should only be used as a last resort for cases in which all closed reduction technique failed. And second one is Mataju technique. This is also a semi-closed method of reduction, minimally invasive, and this is done by flexible intramedullary nailing. This technique is done under general anesthesia. Fluoroscopic arrangement is a must. Here, sharp or tapered stainless steel or titanium nail of diameter 1.5 to 2.5 millimeter are usually used. Entry hole of the nail is made 10 to 15 millimeter above the distal radial physis. Care must be taken to avoid damage to the radial vein and the sensory bunch of the radial nerve, and care should be taken not to slip the owl anteriorly, not to endanger the radial artery. Here diagrammatic representation of this technique. Here the entry hole, this is 10 to 15 millimeter above the distal radial physis. Entry hole is made about 10 to 15 millimeter size. Forearm is in neutral position. Entry and a sharp stainless steel wire or a titanium nail is worn with a T-handle, first of all, and it is introduced through the entry hole and it is passed along the medullary canal. This may be sometimes difficult. So, to and fro movement, clock or counterclockwise movement of the T-handle, or at the same time, mild supination and pronation movement of the forearm may be necessary for easy introduction of this nail. And the nail is advanced up to the fracture point, where the fracture end is purchased with the sharp tip of the nail by a gentle hammer. If there is complete shipment of the fracture fragment, it will not purchase anything. Then we may have to assist with it a percutaneous reduction. It will help, or we can push the fracture portion with our thumb as described by Peterson or Kaplan. And when some point of this fracture end will come at the tip of the nail, advancing tip of the nail, we should purchase it with gentle hammer. Next time, by rotation of the T-handle, clockwise or counterclockwise, we can get the desired position of reduction. In case of right-handed injury, usually clockwise rotation of the T-handle is necessary, and into the left-handed injury, injury to the left hand or left forearm, counterclockwise rotation of the T-handle may be necessary here, because the fracture fragment is usually translocated or shifted laterally or posteriorly. Here, case example, this is a Salter-Harris type 2 radial neck fracture, and this is pre-reduction. The nail, sharp end of the nail is advanced up to the fracture line, and the reduction, reasonable amount of reduction is achieved by the intermediary nail. Here is the literature. Here is evaluation of severely displaced radial neck fracture in children treated with elastic stable intermediary nail. This is done by Klitschner et al. They concluded elastic stable intermediary nailing is a minimally invasive technique, allowing stable fixation and providing excellent to good outcome with low complication rate. All the methods, conservative, semi-closed, all methods fail with or without internal fixation. We may have to open as a last resort. Here, there are some indications where open reduction is sometimes less traumatic than multiple attempts percutaneously or conservatively. Here, there is an example here. This is an example. Here, there is fracture end, which is totally shifted. This is the mechanism. This occurs during the dislocation of the elbow. And here, open reduction is done for satisfactory alignment and for satisfactory reduction. This is the post-open reduction film. But if after opening or after method, if it seems stable, no need for internal fixation. But if it seems unstable, even after opening, we may have to fix it internally. How? Most of the time, fixation is not needed after open reduction, but no transcapitular pin. This is the result of using transcapitular pin it may cause breakage at the time or during convalescent period or at the time of removal, there may be every chance of pin breakage. So if we have to use fixation, we must not use transcapital pin. We should place the pin obliquely, avoiding the capitulum. Open reduction was done. This occurred during the process of reduction. The radial head fracture part is lies posteriorly. Here, for the first time, open reduction is indicated. This diagram taken and pictures taken from here, the radial head fracture fixed with transepiphyseal screw supplemented by buttress plate. Here there is also Olecranon fracture and there are some buttressing of the, these are the example of open reduction and internal fixation. The same literature shows excellent to good result is obtained only in 35% cases in open reduction group. This is only 35%. Contrary to the closed reduction group, there is 69 to 73% cases of excellent to good result. There is another literature where open reduction is indicated. They opine proximal radial fractures with totally displaced proximal fragment and residual angulation, especially if associated with lateral shift, for which closed or percutaneous reduction is not successful, should be treated with open surgery. They advocated for open surgery, and open reduction should be performed with minimal injury into osteochondral, ligamentous, and muscular structure to reduce the complication associated with these injuries. The causes of poor results in this significant fracture to the major focal trauma to the bony and soft tissue tissues in
Tapas,
sir.
Can you hear me? You make short because you have Olecranon part also. Already
Okay,
45 minutes.
Fracture part is very short. I'll make
it.
I'm making here, sir. And finally, if every point becomes unsuccessful, we may have to do salvage radial extraction. This is a case of established non-union, and there is total stiffness of their bone. Had to reset the radial head. Closed or semi-closed method of reduction is always preferable to complication. And this is a summary treatment algorithm. Radial neck fracture below 30 reduction, more than 30 degree reduction. If below 30 degree, simple immobilization. More than 30 close reduction. If it becomes successful and stable, then only casting. If unstable, there should be percutaneous spinning should be done. If close reduction becomes unsuccessful, why this is occurring? I don't know. Percutaneous reduction, if successful and stable, no fixation. If unstable, we should go for pin fixation. And if percutaneous reading become unsuccessful, we should go for open reduction. If stable, no fixation. If unstable, we should go for fixation with pin. And this is my paper, which was presented in Boston 2020. We have done, as it is very common injury, we have only 6 patients. We have done the reduction by Metaju technique. All 6 patients achieved good consolidation, excellent elbow function, and there was no incidence of posterior interosseous palsy. So I concluded Metaju technique is safe, minimally invasive, easy to perform, and early result is satisfactory in cases of pediatric radial neck fracture where close reduction fails, but it is technically demanding and facility of image intensifier is a must. This was my paper. Complication. What are the complications? There may be joint stiffness, growth disturbances, epiphysiodesis, radial or synostosis. There may be delayed union, malunion, non-union, or hypertrophic or anarchic ossification, and finally avascular necrosis. Here are some example. This 7 years old baby, this was fixed with a late aggressive open reduction, and the head neck region is good, but the baby developed progressive proximal radial nerve synostosis. There is some chance of delayed union also. Here, union is delayed, but it unites in 8 months. There may be totally non-union. Here, at 3 months, non-union had persisted, and there is maybe also be avian. There is development of heterotropic ossification also. This is an interesting complication. This is very, very rare. What is going there? You see, this is an injury after posterior dislocation, which was treated closed, and there is complete flipping of the radial head. Radial head ta totally ulte ache ekhane. If you can see, and this was treated by open reduction and internal fixation with oblique care. So my home message is the treatment of radial neck fracture can be difficult. The fracture has a 15 to 35% rate of poor to fair results, even with adequate reduction. So counseling the parents before reduction is a must. If there is more than 30 degrees annulation or 3 to 5 millimeter of displacement, fracture reduction is needed. Open reduction has been associated with complications like infection, synostosis, loss of motion, stiffness of the elbow, non-union, and avascular necrosis. If open reduction and interfixation is done, avoid placing the pins across the capitular radial head and limit post-reduction immobilization for 2 to 3 weeks. This is my take-home message. And this is all about radial neck fracture. Now, in short, I am going to present about fracture Olecranon in children. First of all, we see the ossification process, and everybody of us know there is no ossification center up to 8 to 10 years age. It arises at 2 separate apophyses. One is traction apophysis by 12 years. One is traction apophysis and one is articular apophysis in tip of the olecranon. How to classify geographically or anatomically? There may be physical injury, there may be metaphysical injury, and mechanically there may be flexion injury, extended injury, and shear injury. Mechanical injury is more important according to treatment, regarding treatment. Here, how flexion injuries occur? Here, there is a fall on flexed or semi-flexed elbow, violent contraction, simultaneous violent contraction with biceps from the front and triceps from behind, and there is failure of the extensor mechanism, and there is opening at the posterior cortex of the proximal ulna, that is olecranon. Clinically, we can palpate a large gap just beyond the tip of the olecranon, and radially like this, there is wide separation of the fracture fragment. How to manage? If there is minimal or no gap, the treatment in flexion injury may be conservative, but we must have to keep in mind that the long arm cast should be worn in full extension. If there is gap in the extensor mechanism, wide gap, we must have to de-establish the posterior cortex, and we can use tension band principle, we can use K-wire, circular screws, or thick absorbable sutures. Like this, here this is fixed with a K-wire and circular, but this construct is very stable, can be used in older children, but a circular wire can cut out through the soft bone and cartilage in the younger. So in younger age group, we should not use this type of wire. Instead, we can use tension bending can be done with thick absorbable suture, and which need not to remove, and K-wire can be removed by semi-invasive technique under local anesthesia. It can be done with screw also. And this is my case example. There is a fracture, and this was fixed with K-wire, 2 parallel K-wire, and tension bending was applied with 2 thick absorbable wires. And the tip of the wire was kept outside for successive removal, and there is good consolidation. How extension fracture occurs? Here, fall on extended elbow. There is a cortical gap anteriorly, but here posterior periosteum still remains intact. Extensor mechanism is not disrupted fully. Radius and ulna can be shifted as an one unit anteriorly. How to treat? Posterior cortex here can be used as a tension band. We must have to close the gap by immobilizing the elbow in hyperflexed position for vascularity. Oblique screws can be used for more stability. Third one is shear injuries. Here, it can occur in flexed or extended elbow. Direct blow by a rod or fall can cause this injury. Usually comminuted fracture, but periosteum often remained intact. And both radius and ulna can shift as the unit also here also. And here, treatment is simple immobilization of the forearm in 90-degree flexion of the elbow. If there is the child is relatively older, it can be fixed with plate. And this is all about, in a nutshell, in Olecranon fracture. And this is all about my presentation. And thank you for patience hearing, everybody.
Okay. Excuse me. This is the vivid talk. Excellent put. Now, this is the time for the question and answer session. Please unshare the screen. Tapas, unshare the screen.
Yes, sir. He has answered the screen, sir. You just read out the question.
Read out.
Screen share.
Unshare. Okay.
Yes, question is,
yes,
what is the ideal time? I have seen the question. What is the ideal time of removal of implant? Here, where we use Metaju technique, we should remove it in 2nd or 3rd postoperative month. That is 8 to 12 weeks.
Dr. Tapas, let our moderator sort out the questions so that he will ask you if you want to answer that one.
Yes.
Let Dr. Dipankar sir sort out the question, please.
Sir, please.
Dipankar. You don't have time to take all the questions. You sort out the questions and important few questions you ask Tapas, because we are already 20 minutes. Tapas, thank you very much, Tapas, but you have taken more time, 20 minutes more. So we will sort out the question with the
How to diagnose the unoccupied radial head injury? How to diagnose unoccupied radial head injury?
Okay, sir. Thank you for the very good question. If we must have a high index of suspicion because radial head may be cartilaginous, unoccupied, it is not properly seen in X-ray. If we have high index of suspicion, we can diagnose it by performing an MRI.
Before MRI, you have got a lot of investigation. In the X-ray, you will got supinator PET sign, and there is smoothing of the metaphyseal area. That is also plain radiograph, and finally MRI. Okay. The next question from Vipul Kumar: how do you experience posterior interosseous nerve injury during the Parkinson's reduction? Well, what is the experience of posterior interosseous nerve injury?
Or how we can avoid? Tapas.
I have already mentioned, sir, in my presentation, we must have to pronate the forearm, and we can make a small incision of 10 millimeter size. We can retract the avoidable structure which should be avoided and which may be injured. we can go directly to the bone with this percutaneous technique. But if we introduce properly from the posterior aspect by pronating the elbow, there is less chance, very minimum chance of injuring the posterior anterior nerve. Anything, Kori sir, please?
No, yes, you are right. You have to pronate the forearm and there is less chance. Next question.
And it must, sir, another answer, it must be above the radial head, radial tuberosity. Should be above the radial city, so posterior lies below the radial tuberosity.
The fracture is above the radial tuberosity.
Radial tuberosity.
The fracture is also above the radial tuberosity. So no question.
Yes, sir.
Next question.
What is the ideal time for implant?
One thing, sir, I add, there is a safe zone of 100 degree, which is away from the proximal radioulnar joint. We should avoid this zone. And by supinating or pronating, by pronating, we can avoid this zone. And this safe zone is about 100 degrees, sir.
No.
Next
The
question.
idea of the safe zone is not that. The safe zone, you can, this zone does not come in contact during the pronation supination. 100 to 110 degree. This is the safe zone. You can use the safe zone with percutaneous of the ear. This is not come in contact with the pronation supination. What is the ideal time of implant removal in case of olecranon fracture?
I have already answered the question. The ideal time of implant removal is if in case of metazu technique, where the tip of the nail.
No metazu. Olecranon fracture. Ideal time of
2 to 3 weeks, sir. 2 to 3 weeks is sufficient, I think. And the book and literature says it.
2 to 3 weeks, sir. It is not.
Yes, sir.
No. Tapas.
Olecranon fracture.
Olecranon fracture. When you are fixing
Olecranon, sir.
Tension band. Okay.
Olecranon.
In case of olecranon, I think I have done those cases. I have removed the implant. In 2 cases, I kept the parallel K wire outside, and I removed the implant in 3 weeks. This K wire removed the 3 weeks, but kept the back slab for more 3 weeks, sir. Before easily movement.
But in case of tension band.
Tension band, you have to keep it for 2 to 3 months at least.
Yes, sir.
There is optimum type of union 3 to 9 weeks, 13 weeks. So you should be remove the pin after the 13 weeks. Okay.
Next one. Next question.
How can you use ultrasonography for the diagnosis of unoccupied radial head? It is already. Fracture reduced by metazu technique হয়ে গেছে আচ্ছা why pronation supination is restricted in radial head injury? Why pronation supination restricted in radial head injury?
Why pronation and supination is restricted in radial head injury?
Yes.
Simply there may be a chance of malunion, and there may be impingement. This is called cam effect. There may be, if there is malunion, there is more than 30 degree angulation, which is not readily removable, there will be a chance of restriction of pronation and supination.
Exactly. There is simple talk is there is distortion the arc of rotation which passes from head to metaphysis. Okay.
Right, sir.
আর কোশ্চেন তো আমার এই চ্যাট বক্সে
আচ্ছা ঠিক আছে, অনেক টাইমও হয়ে গেছে।
স্যার আরো কোশ্চেন ছিল, ওই কয়েকজন প্রশ্ন করছে তাপস,
বলেন
যে মেটাইজো টেকনিকটা কতদিন পরে আমরা করতে পারবো, কত পুরনো হলে করতে পারবো? কয়েকজন প্রশ্ন করছে।
There is no clear-cut idea, and in the book we have literature I have read so far, there is no clear-cut idea. And my 6 cases, this was done by 10 days, sir. Sir, can you?
আমি যেটা পেয়েছি সেখানে বলা আছে যে 7 দিনের পরে হয়ে গেলে মেটাইজো টেকনিক করাটা ভেরি ডিফিকাল্ট হতে পারে।
Yes, I agree with Rumel. It is difficult after a week. তাই বলা আছে। হ্যাঁ, it is to be done always in first case. After
Yes, sir.
1 week, it will be difficult. Next.
স্যার ওই
Rumail, any more question?
KY রিলেটেড কিছু কোশ্চেন আছে স্যার। ডিউরেশন অফ দ্য KY হয়ে গেল স্যার,
Sir,
আর নাম্বার অফ দ্য KY ইন রেডিয়াল নেক ফ্র্যাকচার স্যার।
number of KR.
নাম্বার অফ KY,
If after reduction it becomes stable, it
নাম্বার
stays stable.
নাম্বার 1
How
2
many? 1 or 2?
2, sir, 2.
2.
2 ওকে
2, sir.
এর 1 or 2 স্যার। এটা আরেকটা কোশ্চেন আছে, whether antigate and retrograde.
One may cause rotation, sir. Fragment.
There is lot of publication, the one,
Sir.
but it should be past the opposite cortex, but there is the chance of retropulsion due to
Sir, I
antigate.
am asking
ঠিক আছে,
sir
but
about
you
the
have
number.
to immobilize in plaster.
স্যার আপনি কোনটা কয়টা ইয়া করেন?
আমিও একটাও দেই। হ্যাঁ, তো যেটা তাপস বললো যে আমরা তো অনেক সময় ওপেন রিডাকশন করে স্টেবল থাকলে প্লাস্টার দিয়ে দেই উইদাউট। হ্যাঁ, আবার আমার কয়েকটা কেস করা আছে যে ওপেন রিডাকশন করে রেট্রোগ্রেড কেওয়ার দেওয়া থ্রো দি সেপ্ট, ভেটাজু টেকনিকের মতো থ্রো দি সেপ্ট কেওয়ার ভিতরে দিয়ে দিলাম। দিস ইজ অলসো পসিবল।
এটা উইলকিন স্যার এইভাবেই করছেন স্যার, রেট্রোগ্রেড। ওকে,
আচ্ছা, ওই তাপসকে আমি একটা অ্যাডভাইস দিব যে many of your slides are taken from the Professor Kai Wilkinson lecture.
Right, sir. Right,
So
sir. Right, sir.
you must add a courtesy to Professor
Right.
Wilkins in your lecture.
Yes, sir.
Yes.
Yes, sir. Thank you, sir, for your remark and advice.
Next.
আচ্ছা ওই ববি আপনার চ্যাট বক্সে যদি থাকে, এখন আমাদের মাত্র 9টা বাজে, 1 ঘন্টা হলো, যদি আরো কিছু কোশ্চেন স্যার অ্যাবাউট প্যানেলিস্ট যদি হয় তাহলে স্যার অ্যাটেন্ডিদের
ঠিক
আরো।
আছে, আমার মনে হয় যে আমরা সিনিয়রদেরটা ববি সিনিয়রদেরটা আনমিউট করো, তাইলে আমরা আর একটু ডিসকাস করব। সিনিয়র টিচারদেরটা,
সিনিয়র টিচার প্যানেলিস্ট, সিনিয়র টিচার যেটা ওই
আমি এখন আনমিউট করার অপশনটা অন করে দিচ্ছি। So please only our senior teachers be participate in our conversation for the next 10 minutes.
Not 10 to maximum 15 minutes more.
এখন প্রফেসর ইকবাল কাবি স্যার। হ্যালো স্যার, স্যার শোনা যাচ্ছে?
আমার কথা শোনা যাচ্ছে?
স্যার শোনা যাচ্ছে। আপনি প্লিজ share your experience in these 3 of the topics which you want to express your experience. Share, please share.
আমি আমার জুনিয়র কলিগদের উদ্দেশ্যে এই এলবো ইনজুরি একটা কথাই আমি অ্যাড করব সীমিত সময়, সেটা হচ্ছে ফিজিওথেরাপি। একটা ইনজুরি হওয়ার পরে it takes time to get the range of movement back. Be very careful in referring the patient to a physiotherapist. Remember, forceful flexion and extension of the elbow will lead to myositis ossificans and more stiffness. I never refer my children, my pediatric cases of elbows to the physiotherapist. I believe the children are the best physiotherapist. This was said by some renowned surgeon, Ayer Brook. বাচ্চাদেরকে আটকায় রাখা যায় না, তারা হাত পা তারা ছুটবেই। বাপ মাকে বলে দিতে হবে যে বাচ্চাকে স্বাধীনভাবে ঘোরাফেরা করতে দেন, কোনো অসুবিধা নাই, দেখবেন সব ঠিক হয়ে যাচ্ছে এবং ঠিক হয়েও যায় 1 মাস পর।
Thank you for your nice advice. It should be considered by all the junior surgeons, pediatric surgeons, as well junior surgeons, general orthopedic surgeons as well. Sir,
and it is not only for the children, even in adult. আমি জুনিয়রদের বলবো, don't refer the patients to the physiotherapist for elbow problem.
Sir,
active movement will help.
Exactly. এটা আমার পরিসরও করে থাকেন অলওয়েজ। এটা আসলে আমাদের অনেক শিক্ষণীয় আছে এই ব্যাপারটাই। স্যার কামরুল আলম সালে স্যার, what are your experience about the tense capitular pains which we did 5 years back when we became the member of the pediatric orthopedics? society. We did always transcapitular pin. I also did several times 5 years back. Sir, sir, hello, sir. Sir.
আচ্ছা, এখানে দেখা যাচ্ছে যে শহীদুজ্জামান এবং
স্যারকে আসতেছেন।
হ্যাঁ, শহীদুজ্জামান
প্রফেসর মঈনুদ্দিন, good speaker of the last session.
আসসালামু আলাইকুম।
আপনার এক্সপেরিয়েন্স ট্রান্সক্যাপিটালার পিন, এটা আপনি আপনার লাইফও করছেন, আমরাও করেছি। এটা যদিও এটা এখন প্রহিবিট করতেছি, কিন্তু এক্সপেরিয়েন্স আছে কিনা? বিটার এক্সপেরিয়েন্স?
I have the experience that some bitter experience also. Transcapitular pain I have applied, but sometimes it is very difficult to remove. During removal, a part of the pin may remain in situ, and so this is the nowadays it is inhibit to give a transcapitular pain. It is better. Our President Koirisa told that the retrograde pinning is much more better. So nowadays I always avoid this transcapitular pin, and I have the two supplements also for the younger surgeons. If somebody tells that how much attempt you will take to do the close reduction, there are some question I have seen that we didn't answer it. I want to tell this answer that you should take 2 or 3 chances maximum for close reduction and percutaneous pinning. If you cannot do it by the 2 chances or 3 chances, then you go for the open reduction for the young surgeon, because
that's supracondylar effects.
Pinning, you can disturb many soft tissues and maybe the injuries. So it is better to go for the open reduction. For multiple type 6, 7, 10 times trying before doing this thing. Go for after 2, 3 chance you have to go for open reduction. One of the other things is that we have many where we have not the MRI or there is no chance of arthrogram. Arthrogram is one of the diagnostic thing for diagnosis of the fracture neck and head of radius. We can take a plain good X-ray, and after the X-ray we can get some soft tissue findings. These soft tissue findings, you can get a capitular fat pad sign. The fat pad sign, sometimes fat pad is displacing from the in front of the there is the radial head and neck. So we can see this also, and we can see also that there is a displacement of the fat in the supinator muscle. So the 2 signs
already discussed.
Thank you very much.
Sorry, sir, already discussed this topic. Shamal Devnath, Professor Shamal Devnath.
Thank you, sir. Thank you. Thank you for inviting me to say something.
Welcome. About what
is very nice presentation. Tapas has presented very nicely and elaborated it. I had a question. I probably wrote a question to you, but you did not answer. How do you assess the stability during closed or open reduction of the displaced radial neck fracture?
Will answer.
Clinically, if I have the serum facility, you can assess it in the video mode of the image intensifier.
আচ্ছা, ঠিক আছে, Tapas, I help you. Pronation and supination of the forearm during the procedure, you can see that it is moving. The radial head is moving fully. Then it is in the one part of the periosternum. This is the stability.
This is the answer, and another is radiocapitular alignment. Capitular alignment in extension.
Shahiduzzaman Kedam.
This is sir. Professor Shahiduzzaman sir, one of the best academician. Sir, your experience.
I have got 1 or 2 comments about the presentation. Dr. Tapas, you have excellently described the whole thing, but to tell you very frankly, you have used many slides. You should reduce the number of slides in your presentations. Number 1. Number 2, too many slides. And number 2 is about advising MRI to in children. We should actually, I feel we should advise an MRI for a radial head or neck fracture, because for a children, if you have to advise a MRI, then they have to undergo a general anesthesia. So that is very dangerous in that circumstances. So please do not prescribe MRI for children fractures or these things. You try to diagnose it by good X-rays. And other things, everything has been described. And these are the 2 comments I had. And about the radial head, about the transcapitular pin, which we are talking. Actually, it breaks. Why? Because they start moving. They start moving the elbow after fixation. because you cannot refrain them from moving the elbow because you cannot totally immobilize the fracture in a cast. So there is always a micro movement, and that actually causes the fractures. So it is always better to avoid transcapsular fractures. We used to use it in adults while reducing the dislocations. So we used to reduce the dislocation of the elbow and we used to hold it tight by this transcapsular pin. But actually that is very dangerous because it might break due to micromotions. So this is all these things I had as a comment. Thank you very much for everything. It's good arrangement. Good topic.
Thank you, sir. Thank you.
Valuable
comment. I take one from the panelist, Professor Said, Professor Green Life Hospital. Are you here, Professor Said? Professor Said, sir, are you here? Okay.
No, Said.
Sir, now we have our two galaxy of the Pediatric Orthopedic Society, Society of Pediatric Orthopedic Society of Bangladesh. Before concluding, I am searching for Professor Goni Mullah. Goni Mullah, are you here? Professor Goni Mullah, Director NITER. Sir, are you here?
না মনে হয়
ওকে
তো দেখতেছি না
আমার একটু কথা হইছে আসার কথা স্যার স্যার ঠিক আছে ওকে নাও I would like to request Dr. Sorar Ibn Salam, our secretary and one of the attraction of the two, please deliver your speech and
Romel
about the meeting on the next webinar.
Romel.
Sir. So thank you very much, Professor Talukder and all the participants, our teachers. I can see Professor Bari sir is there, Professor Shwedhujaman sir, Professor Kavi sir is there. Thank you, sir, both for being with this program. The next program is on pediatric radial and ulnar shaft fractures and the distal radius ulnar fracture. And I'll be the speaker in the next session, next Friday at 8 p.m. So we welcome you all. We have two more pediatric upper limb talks. One will be Montegia and Miss Montegia, both by Professor R.R. Koiri, and one probably will be on hand bone fractures. After that, we'll go to lower limbs fracture, neck, femur, shaft, and all those. So thank you very much, everyone, to be with us. And I thank you for being here.
Let's pray that we remain alive till next Friday.
Sir, that's true, sir.
That's true. That's true.
Big question.
Sir, I would like to request our chairperson of
comments from Bari sir
to summarize this and please start your speech.
I think welcome you all. I think I agree with Shwedhujaman. Let's pray for all of us so that we can join in the next Friday. The situation is not that good about the corona problem, but next meeting, next Friday, just at 8, I will advise Sarwar to give the lecture within half an hour time, not more than that. And the Tapas lecture is very well illustrated, very good, but he has not maintained the time. So I will request Tapas to review, as Shwedhujaman also said, that you have to make it a bit short. So thank you, Tapas. From the juniors, this was a very good lecture and well presented. And I advise all the speakers, thank you all for the patient sharing. And to this Friday, today I think the participants are a bit less. I don't know why, but I will ask Kumer to circulate it more for the next week. Thank you very much. Thank you all once again. And at least on Friday we can see each other. Mehdi has not told anything, but thank you, Mehdi, for participating. Thank you all. Thank you all. Thank you, everybody.
Stay safe. Stay safe.
Stay safe. Stay at home as
Thank
much
you,
as possible.
Tapas. ইলাবোরেটলি করেছো, অনেক সুন্দর হয়েছে। প্রথম ওয়েবিনার হচ্ছে, আল্লাহর রহমতে আমাদের পেডিয়াট্রিক্সের সবাই ভালোই করছে। আস্তে আস্তে স্যার আরো কারেকশন হবে। এখন হয়তো একটু স্লাইড ইয়ে হচ্ছে, আরো গেলে এক্সপেরিয়েন্স হবে যে আরো কম স্লাইড নিতে হবে। ও সুন্দর করেছে।
ভালো বলেছে, ভালো। থ্যাংক ইউ ভেরি
দোয়া
মাচ।
করেন যাতে তাড়াতাড়ি ফেস টু ফেস করতে পারি।
হ্যাঁ,
তাড়াতাড়ি ফেস টু ফেস করতে পারি।
এখন স্যার অনেক বেশি লোকজন স্যার করোনায় আক্রান্ত স্যার, অনেকের ফ্যামিলি স্ট্রেসড আছে স্যার, অনেক সমস্যা আছে।
হ্যাঁ, সেটাই তো বললাম, এই জন্যই let us pray for everybody.
Okay, bye bye.
Bye bye. Bye bye.
দোয়া করবেন স্যার সবাই।
We are concluding the session. Thank you all.
Thank you.